we were talking about genetic counseling, and this was the last slide that we talked about, and I told you that after actually making a pedigree, how you can address an individual in the pedigree. The first thing is generation number, 1, 2, 3, 4 for this pedigree, and then each individual in each generation numbered from left to right. Okay? So in this pedigree, what individuals are affected? Any others?
Third generation, fourth and sixth.
Generation
Three,
3,
fourth and sixth.
4, and 6. And what individuals are blood relatives?
Generation 3, second and third are related and
They are blood related. They have blood related marriage. What
Yeah,
percent?
the third one and
second one.
Third thing, blood
Yeah,
related.
just you need to say 3, 2, and 3, 3.
Yeah.
And for the affected individual, 3, 4, and 3, 6. Okay, this is the way you can address an individual in the pedigree. And after we actually draw a pedigree, next step is to establish the diagnosis and also the pattern of inheritance based on the pedigree. You gather some information from the family, and you have done some physical examination, and maybe you have done some laboratory tests or genetic tests, and then you now, next step now you are going to establish the diagnosis and then the pattern of inheritance. As we said, to actually design the pattern of inheritance, we will have some problems that make actually our pattern of inheritance a little bit difficult. What is the pattern of inheritance? We talk about the problem that we may face. One was genetic heterogeneity. We talked about genetic heterogeneity. You remember? We have different genetic heterogeneity. Genetic heterogeneity means different genes may cause the same phenotype, or different gene may cause this different phenotype. And also we had allelic heterogeneity and lupus heterogeneity. Allelic heterogeneity was different mutation on the same gene may cause same phenotype, and lupus heterogeneity is different mutation on the same gene. In different lupus may cause the same actually phenotype. We also need to talk about the etiologic heterogeneity, about the penetrance and expressivity and age of onset that may make some problem for us. We talk about the genetic heterogeneity. Different gene, different mechanisms may cause the same phenotype. So we cannot actually design the pattern of inheritance for some of these disorders. For example, for Ehlers-Danlos, for Charcot-Marie-Tooth, for retinitis pigmentosa, and for many other genetic disorders, we may have all 3 patterns of inheritance: autosomal dominant, autosomal recessive, and X-linked But for each pedigree, for each family, we just have one of these pattern of inheritance. I mean, based on the diagnosis, we cannot assign the pattern of inheritance. Okay, maybe one family has retinitis pigmentosa, but the pattern of inheritance in this family is autosomal dominant. Another family also they have retinitis pigmentosa, but the pattern of inheritance in this family is autosomal recessive. And another family the same phenotype, but the pattern of inheritance is X recessive. So we make the diagnosis, and then based on the pedigree, we can actually say what is the pattern of inheritance for this disease in the family. Another problem that may make difficult to have assign the pattern of inheritance is etiology heterogeneity. For some disorders, like deafness, like mental retardation, both genetic etiology and non-genetic etiology can cause the same phenotype. For example, we have some families who has, for example, deafness. An individual or two or more individuals have deafness, but the pattern of inheritance, the etiology is genetic. But some other families have deafness, but not because of the genetic etiology. Maybe genetic and non-genetic etiology causes the disease on that family. So if we can find out the actually genetic base for ethnic disorders, then we can assign the pattern of inheritance. So another problem that we faced was etiologic heterogeneity. And there are some other factors that affect the pedigree. One of them is penetrance. What's the penetrance? And how it can affect the pedigree? Penetrance is the percentage of individuals or people who have genotype and they also have the phenotype. What does it mean? It means some individual may have mutation, may have genotype, but they do not express the phenotype. Okay? So, the reason that the penetrance can affect the pedigree is, I talked about it yesterday. Maybe one individual has mutation, but he or she is normal, but he or she has affected children. Okay? We assume that for this family, for this individual, the pattern of inheritance is autosomal recessive. Okay, because both parents are normal, but one of them has mutation, but he or she didn't express the phenotype because of the non-phenotypes. Okay? So it will make us mistake because of the actually non-penetrance of disease in the family. For example, if we have a family with 10 members, okay, 4 of them are affected. Okay, and we genotype the family and we find out that those affected members, 4 affected members has mutation. What's the penetrance in this family? 10 family members. We have a family with 10 members. 4 of them are affected. Okay? We genotype the whole family. We do the genetic test for the whole family, and we find out these 4 affected members have mutation. What's the penetrance in this family? 4. The members who percentage, read the benefit. Read it exactly percentage of people with a genotype who are actually affected.
40%.
40%,
Are actually.
40%. What are you doing? What's the penetrance in this one? All of you agree with 40%?
Yes.
Why?
No, because you said that in total there are 10 family members within them, 4 have mutated genes. So it is 40% out of 10.
The percentage of individuals or people who have the
But
genotype.
it can be, maybe it can differ because some of them may show phenotype and some might not.
Uh, No.
Till the time we don't see who has apparent signs, we cannot say we cannot determine penetrance.
Why?
Till the time we don't see, if we see there is a visible phenotype for the mutated gene, then it won't be included in penetrance. But if there are no visible signs, it's just the genes that
In this example that I said, a family with 10 members, okay, 4 of them are affected. We genotype whole family and we find out that just those 4 affected individuals have mutation. What's the penetrance in this case?
I think
40%, 80%, 100%, 0. Which one?
40%.
40%. 40%. You also think 40%. But the penetrance is 100%. Because 4 family members are affected, and when we do the genetic test, we find out just those affected individuals have mutation. So the percentage of individuals who have the genotype and they express the phenotype at the same.
So in penetrance, we don't calculate the total number of people.
What?
We don't calculate the total number of people.
No.
We just calculate the one who have the genotype.
The genotype and at the same time they have the phenotype. It does depend on the total number of the family.
So it's 100%.
So the
So if just 1%, like if
What?
then it's also 100%.
What?
If just 1%, like
Just 1% will affect it?
Yes. It is still 100%.
No. For example, in this family, if we do genotype, 10 family members, 4 of them are affected, we do the genotype for the whole family, and we find out that 5 individuals have mutation, but 4 of them is affected. 4 of them have
Yes, they should.
phenotype. For the sake for this family, the penetrance would be
80%.
80%. If we find out that, for example, 8 individuals have mutation. 8 individuals have mutation, but 4 of them are affected. Then the penetrance will be 50%. Okay? If the total number of family is 20, we have 20 family members, 4 of them are affected, we do the genotype and we find out just those 4 affected individuals have mutation. The penetrance is? What's the penetrance?
20% in total number. How many are affected?
4 are affected, and just those 4 affected individuals have mutation.
100%.
100%. The family with 20 members, 4 are affected, 5 have mutation.
Again, 80%.
80%. It's not depend on the total number of the family. It depends on the number of individuals who have mutation and they have phenotype at the same time. How it can affect the pedigree? As I said, maybe we have a family, a couple, both of them are healthy, but they have affected individual, affected children. Okay? Based on the phenotype, we say parents are normal. So the pattern of inheritance is autosomal recessive, but it's actually autosomal dominant, but because of the non-penetrance, one of them did not have
Phenotype.
a phenotype. Okay. Penetrance for each individual is an all or none. It means we cannot say the penetrance in this individual is 80%. The penetrance in this individual is 80. The penetrance is for the family. For each individual, the penetrance is either 0 or 100%. Okay? Either this individual is affected,
Or not affected.
the 100%, if or is not affected. The penetrance is 0
Or
or
100.
100. But the whole family members, we can say the penetrance is 60%, 80%, 90%, based on the percentage of individuals. Another factor that affected pedigree pattern is expressivity. You know, we have some disorders that they have a range of the symptoms, from mild, very mild, to very severe. Okay? Sometimes one individual has the genotype, but the phenotype is very, very mild. Okay? We assume that this individual is healthy, but actually is not healthy. He or she is affected, but the phenotype is very mild in this individual. Another factor is age of onset. Maybe we have some disorders that are late onset. When we draw a pedigree, one individual, we assume he or she is normal, but he or she is below the age of onset, and he may have genotype, and she or he doesn't have any phenotype because of the late onset, because of the he or she is below the age of the onset. And another factor that affects the pattern of inheritance is environmental factor, lacking of accurate information, new mutation, family size. They all may affect the pattern of inheritance or pedigree. Then, when we draw a pedigree, as we said, sometimes we can judge the pattern of inheritance based on the pedigree. Okay. But the reason that we showed you in previous slide may affect the pedigree, and maybe we cannot actually judge about the pattern of inheritance just based on the pedigree. So we need also to have physical examination. We may also need to have some laboratory tests or genetic tests, and then we can assign the pattern of inheritance. but usually the combination of pedigree, physical exam, laboratory test, based on this, we can actually assign the pattern of inheritance. So based on this, actually pattern of inheritance, we can say the disease is either chromosomal, single gene disorders, multifactorial, mitochondrial, or other somatic actually mutation may happen and causes that disease. So as we said, for single gene disorders, we can calculate the risk, but for other pattern of inheritance, we cannot assign the actually risk calculation. So the first thing is we decide that whether the disease is single gene disorder, is mitochondrial disorder, or multifactorial disorder, and then we can calculate the risk order. I showed you and talked about this website, OMIR, Online Mendelian Inheritance in Men. As we said, there are more than 40,000 disorders that are actually listed in this website, and you can find any information you want about the disease, about the pattern of inheritance, about the sign and symptom, about the test, genetic tests that some of them may have genetic tests. Any information that you need, you can find in this website. Each disease has a 6-digit OMIC number or mean number. Okay, a 6-digit OMIC number is specific for each disorder. Okay, if the OMIC number start with 1 or 2, this is 6-digit numbers. If it start with 1 or 2, the pattern of inheritance is usually autosomal. Okay. 1 is autosomal dominant, 2 is for autosomal recessive, but these actually disorders created before May 1994. Okay. If the OMIC number starts with 3, the pattern of inheritance is extinct. If OMIC number starts with 4, the pattern of inheritance is widening. If OMIC number starts with 5, the pattern of inheritance is mitochondrial. And if OMIC number starts with 6, the pattern of inheritance is autosomal, either recessive or dominant, but created after May 1994. So 1, autosomal dominant, 2, autosomal recessive, created before May 1994, and 6 also is autosomal, but we don't know it is autosomal recessive or autosomal dominant. For both of them, it may be possible to have recessive or dominant. So based on this actually information that we calculate, the first thing that we need to the first question that we need to answer after the genetic counseling and making a pedigree is whether the disease is Mendelian inheritance or not. Okay, if the disease has Mendelian pattern of inheritance, then you can calculate the risk. But if the disease is not, doesn't have Mendelian pattern of inheritance, then we cannot calculate the risk. So briefly, genetic counseling is an educational communication process. We calculate the risk for each family based on the family history. It's a non-directive. As we said, we do not direct the family to the way that we want. All healthcare options must discuss about them. We may write a summary of the find out, use the pedigree to find out the probability of having an affected child in the family. The first thing that we need to actually determine after drawing the pedigree is whether the disease is Mendelian or non-Mendelian. If the disease is Mendelian, we need to determine the disease is autosomal or sex-linked. If both sexes are affected, we can say the disease is actually autosomal disorder. Or if just male are affected in the family, then we can say the disease is sex. And after that, we need to assign the disease is autosomal dominant or autosomal recessive or X-linked dominant or X-linked recessive. I showed you this is an autosomal disorder because both sexes are affected almost equally. And the next thing is we assign the disease is recessive or dominant. This is dominant because each individual has an affected parent. Okay, both sexes are affected, right? And we have vertical transmission, so autosomal dominant. And this one is autosomal recessive because affected individual has normal parents. Okay. Any question about the genetic counseling and pedigree?
No.
Our next session is about risk calculation for autosomal and X-linked. We had genetic counseling. We made a pedigree, and we find out the disorder, the disease is Mendelian pattern of inheritance, and then we find out the disease is either autosomal or X-linked, and also either the disease is either recessive or dominant. Then we want to calculate the risk for having an affected child. We talked about the categories of genetic disorders. As I said, we can calculate the risk just for which of these categories?
For all of them,
For all of them?
I guess.
Or just for single disease? Okay. We cannot calculate the exact risk for multifactorial or for complex disorders. It's just for if we made a pedigree and we find out that the disease is single gene disorders, then we can calculate the risk for them. When we want to calculate the risk, we need to quantify and qualify the risk. What does it mean?
Quantify and qualify. They should be calculated properly.
What?
They should be calculated properly.
Yeah, we
The risks.
calculate the risk, okay? We find out the recurrent risk. But we need to place this actually risk that we find out based on the qualification and quantification of the risk. What does it mean?
Well, we must have some classifications for it then.
What?
We must have some classification for it then. For the disease.
Classification?
For the disease. Maybe something like that.
No.
And how much a particular risk can,
How much?
a particular risk affects a person? Like, as you said earlier,
What's the difference between the risk in these two mild or severe? We find out that recurrent risk is 25%. Okay? So what's the difference between mild disease and severe disease?
Like,
Both of them have been 25%.
Both are
You,
right.
you understand what I mean, but you cannot explain exactly. Okay? We will talk about it. What does it mean, qualification of the risk and quantification of the risk? For example, you do genetic counseling, you calculate the risk, you find out the pattern of inheritance, and you say to the family, okay, the recurrent risk for you to having an affected child is 25%. Okay, and he or she will ask you, what does it mean, 25%? You say 1 out of 4.
there is less
Okay.
probability. There is less probability of having a disorder.
No. You calculate the risk, you explain to the individuals that your recurrent risk or the risk of having an affected child for you is 25%. He or she will ask you, what does 25% mean?
Well, if you have 4 children, one of them will have the phenotype or the.
What?
If they have 4 children, basically 25% means they'll have one child which will be affected.
This is the mistake that everybody do.
Okay.
If you say 25% means 1 out of 4, it's a big mistake.
Mhm.
Right, 25% is 1 out of 4, but it doesn't mean if you want to have 4 children, one of them will be affected.
But it will
Okay.
change with the amount of.
So
Yeah.
it will be like if the child is
Chances.
born, there are chances, 25% chances that.
Okay, if you say 1 out of 4, they will say you, okay, we have 1 affected child. Okay, it's okay, we will have 3 healthy child if we want to have 3 more children, all of them will be healthy.
But then again, no, there is no guarantee. Maybe.
No, you said 1 out of 4.
Take my words
They
back.
have 1 affected child. So can you say, okay, can you say if you want to have 4 children, the remaining 3 children will be healthy? Can you promise that?
It's hard to say.
So 1 out of 4 has this misunderstanding. Okay?
Mhm.
1 out of 4 or 25% for every child, not for the family. Okay? You say if you have 1 affected children, maybe the second one will be affected also.
Mhm.
There is a 25% chance for the second child. If you have 2 affected children, there is 25% chance of having the third child to be affected also. Okay? This 25% applied for every child, not for the whole family. Or a family has 3, for example, if a family has 3 healthy children, okay? Can you say the fourth one will be affected?
No.
No. Okay. So actually the exact calculation is for every child. Okay. If you want to have 1 child, maybe there's a chance of 25%, the first one to be affected. 25%, the second one. 25%, the third one. 25%, regardless of previous children. Okay? So, this is a mistake or misunderstanding about the risk. Okay? 25%, 25%, 50%, 30%, 40%. Actually any risk that you calculate is applied for any child, okay, regardless of previous child. The second thing that we need to talk about qualification is actually you need to talk about the other side of the risk. Okay, when you say there is a chance of 25% to have an affected child, the other side is there is a chance of 75% to have a healthy child. Okay, so both sides must be explained. 10% of having an affected child, which means 90% of having an unaffected child. Okay. The other thing that we need to know about it is about the quantification of the risk. What does it mean? That was qualification, and this one is quantification.
Quantity. Something related to that.
You talk about that, okay, but not exactly. About the mild disorders or severe disorders, right? You said maybe some disorders are milder and some disorders are severe, but not exactly that we are going to talk. Sometimes you calculate a risk and you find out, for example, there is a chance of 50% of having a child with some disease like, for example, polydactyly, or syndactyly, or brachydactyly. They are genetic disorders, but they do not affect the normal life, right? Having a chance of, for example, 50% of having a child with polydactyly, the number of risk is high, 50%, 25%. The number of risk is high, but the disease that we are talking about is not very severe disease, okay? So this 50% is not very dangerous. Nobody likes to have a child with polydactyly, or with syndactyly, or with brachydactyly, but it can actually be tolerated by an individual. It doesn't affect the normal life, okay? But sometimes you calculate the risk for Down syndrome, for a neural tube defect. You find out the risk is, for example, 2%, 3%. But this 2%, 3%, 10% is for a very severe disease, for Down syndrome, for neural tube defect. It will affect the life, the normal life. So also you need to actually attend to this quantification of the risk. As I said, the nature of the disease and the long-term life that an individual wants to have with the disease is important also. For some disorders that do not affect the normal life, the high risk, the more than, for example, 50%, 25%, the number of risk is high, but actually the disorder is not very severe, or so it can be tolerated. But for some diseases like Down syndrome or neural tube defect, 1 out of 25 also is high risk, because the disease is very severe. In genetic counseling, as we said, we want to have calculation of exact risk, and we draw a pedigree, we do some genetic tests, we do some biochemical tests, and we find out the pattern of inheritance, for example, X-linked recessive or autosomal recessive. Now we are going to show how to calculate the risk for these disorders, X-linked recessive and autosomal recessive. Before we talk about how to calculate the risk, we need to talk about two or three actually concepts. One is the bias theorem. You know about it? It's not related to genetic, just okay, but it's used for genetic counseling. If you have some information about a family, okay, then you calculate the risk for that family. If you find out more information about that family, then the risk calculation will be changed. Okay, at the beginning, for example, you have some information. After a few weeks or a few months, you got more information from that family. Then you need to update the risk calculation. Okay, based on the new information. Okay, this is bias theorem. This is applied for genetic counseling. The other thing that you need to know is the basic probability, the AND rule and the OR rule. You know about it? The law of addition or multiplication. Know about it?
I think we studied this before, yeah.
What is additivity principle and what is multiplication principle? Just remember these actual principles, then we'll use these principles in this calculation. What is additivity principle?
Well, nothing. I won't say anything.
If two events cannot happen at the same time.
Mm-hmm.
Okay. Two events cannot happen at the same time. The chance of happening these two events is the sum of each event. The sum of happening of each event. For example, a woman is pregnant. Okay, the chance of having a boy is 50%. The chance of having a girl is 50%. These two events, having a boy and having a girl or having a girl, cannot happen at the same time. Okay, she cannot have boy and girl at the same time. Two events cannot happen at the same time. The chance of having a boy or girl is 50% plus 50%. Right? Right? A woman is pregnant. The chance of having a boy is 50%. The chance of having a girl is 50%. These two events cannot happen at the same time. The chance of having a boy or girl for this woman is 50% plus 50%. This is additivity principle. Okay? What about multiplication principle?
Joint occurrence. For both of the things to happen at the same time?
If two or more events can happen at the same time. Okay?
The probability of them.
The probability of having these two events is multiplication of probability of each event. An example, a woman is pregnant, twin pregnant, right? Not single, twin pregnant. The chance of having the first actually fetus to be boy is 50%. Okay, to be a girl is 50%. The second
Is
one,
also
the chance of being a boy is 50%, and the chance of being a girl is
50%.
50%. For this woman, the chance of having two boys or two girls, okay, is 50% for the first one to be a boy, 50% for the second one to be a boy, multiplication of 50% multiplied by 50% is 25%.
100.
Okay? Right? These two events can happen at the same time. Having two girls, the chance of having a girl for the first one is 50%, for the second one is 50%. Having two girls at the same time is 50% multiplied by 50% is 25%. Right? The chance of having a boy and a girl.
That's also
The chance of having a boy and a girl.
50 and 50.
How? Because 25%, the remaining, it is 50%.
This is also 20.
The first one to be a boy is 50%. The second one to be a girl is 50%.
25%.
50% multiplied by 50% is
25.
25%.
Okay, so that's
The first one to be a
Girl.
girl,
and second one to
the
be a
second
boy.
one to be a boy is
25.
50% multiplied by 50% is 25%. Two events, 25% plus 25%. Okay? The first one to be a boy, the second one to be a girl, the first one to be a girl, the second one to be a boy, then additivity of this 25% is 50%.
50%.
Okay? Two events can happen at the same time. And also you need to know about some other terms to use for this calculation, about the basic probability. The first thing is prior probability. When you want to calculate the risk, you have a prior probability for that family based on the actually genetic information or based on the actually family history and ancestral actually information. This is prior probability. The second thing is conditional probability based on the observation of the number of individuals in the family or number of offspring or the result of a test. This is conditional. That may modify the prior probability. The third one is joint probability or combined probability, the resulting probability for each event. We will discuss about them when we want to calculate this, okay? Joint probability, the resulting probability for each event or outcome, and the final probability is exact probability for each event. Joint probability for that event divided by sum of all the joint probabilities. Just remember these, remember this one, and then we use them to see how you can calculate. What is the possibility of individual 3 in this pedigree to be a carrier for Duchenne muscular dystrophy? Duchenne muscular dystrophy is an X-linked recessive disease. Okay, we want to calculate the risk for individual three to find out what is the possibility of being a carrier for Duchenne muscular dystrophy. You want to have a rest or you want to continue? No?
Continue for 10 minutes, then we'll have a break.
Continue for 10 minutes.
We can continue for 10 minutes, after that we
Okay.
can have a break.
The first thing that we need to know about is about obligatory carriers. Okay? In this pedigree, actually, who are in obligatory carriers? You know what's obligatory carrier? It's 100%, there's a possibility of 100% to be a carrier.
Mhm.
Okay? This is obligatory carrier. We talk about it for autosomal recessive disease. The parents of an affected individual are obligatory.
Obligatory carriers.
The children of an affected individual are obligatory.
Obligatory carriers.
For X-linked recessive, the mothers of an affected boy is
Is
obligatory.
a obligatory carrier.
Okay? So in this pedigree, what individuals are obligatory carrier?
First generation, second.
1, 2. 1, 2. Right? And the next one?
Generation 2. All of them?
All of them?
Well, I mean, 4 is there. 3 is also an obligate carrier. In
3,
No,
2, 3.
yeah, like because she
2,
died.
3 is affected.
and second.
Carrier.
4 is second generation.
4, 2, 4.
Yeah,
2, 4, not 4, 2. Okay?
2, 4.
2, 4. First, you need to say generation and then individual one. 2, 4. Okay, 1, 2, and 2, 4 are obligatory, right? Because they have affected boys and also affected brothers. Okay? But if they don't have affected brothers, this also would be okay. But maybe having an affected brothers will help us to find out that they are obligatory carriers. Okay? Now we want to calculate the risk for 3, 3. 3, 3. She wants to know what's the possibility of having to being a carrier and having affected boys. Okay. The first thing that we need to know, we need to calculate the risk for 2, 2. 2, 2 is this one.
25%.
2, 2 is this one. Okay. The mother of 3, 3. Right? To calculate the risk to see what's the probability of having to being a carrier for 2, 2. Right? If we want to calculate the risk not very exactly, we can say, okay, the mother of this individual 1, 2 is obligatory carrier, right? There is a chance of 50% of having this individual being a carrier, right? Her mother is obligatory carrier. There is a 50% of chance that transmitting the X chromosome to her daughter, right? And there is a 50% of transmitting the chromosome from 2 to 50% multiplied by 50% is 25%.
25%.
Right? Right?
Yes.
But this is not very exact risk calculation because we have more information in this pedigree. This is the, here is we use that bias theory. Okay? We have this information in the pedigree, then we can change. Now you will see that the risk will be changed. Okay? The first thing that we need to calculate is what is the risk of two to be a carrier. Okay? If her mother is carrier, obligatory carrier, the prior probability for individual 2 is 50%. Right?
Yes.
50% to be heterozygote carrier, 50% to be
Homozygous normal.
normal. Okay? This is prior probability. You remember we talked about the probabilities, prior probability, conditional probability, joint probabilities, and exact probability. Prior probability is based on genetic information, is based on ancestral information. Okay? Based on this information, she is 1, 2 is obligatory carrier. For this individual, 50% there is a chance of being a carrier, 50% of chance of being a normal. Okay? This is prior. Now we are going to talk about the conditional probability. What was the conditional probability?
It was to have something that modifies the prior probability.
Something that modifies the prior probability. New information, number of offsprings, the result of the test. This is new information that may modify the prior probability. Okay? For this individual, 2, if she is obligated, she is a carrier, 50% of chance of being a carrier, and at the same time, she has 3 healthy boys. Right? 3 healthy boys. 1, 2, 3. Right? This is conditional probability. New information or number of offsprings or the result of the test that change the prior probability. This is conditional probability. Being a carrier and having 3 healthy boys at the same time. For each boy to be healthy, there is a chance of 50%. Okay? If she is carrier, there is a 50% chance of having a healthy boy, 50% chance of having a healthy boy for the second boy, 50% of chance of having a healthy boy for the third boy. Okay? These 3 events, first boy, second boy, and third boy, happen at the same time. Right? Multiplication of each probability. It is 50% multiplied by 50% multiplied by 50%. Okay? Which is 1 out of 8. Okay? The chance of being heterozygote carrier and having 3 healthy boys at the same time. This is conditional probability. The third one is joint probability. What was the joint probability?
It was probability of any event that is occurring.
Prior probability multiplied by joint probability for each event. Right? Prior probability for this event being a carrier is 1 out of 2. Right? Conditional probability for this event is 1 out of 8, and multiplied by each other is 1. 16, right? So, being a carrier, having 3 healthy boys at the same time, joint probability is 1/60, right?
Mhm.
And now we are going to calculate the posterior probability or exact probability. What was posterior probability? Joint probability for that event
Upon some
divided by all joint
joint events.
probabilities.
Probabilities.
For this one also the joint probability was 1 out of 2. Right? So, joint probability for this event is 1/16. Joint probability for this event is 1 out of 2. 1/16 divided by
116 plus
sum of
1, 2.
both joint probabilities, which is 1 out of 9. The exact probability of individual 2 to be a carrier is not 25%. We said her mother is obligatory carrier. There is a chance of 50% of this individual to be a carrier. But based on new information, what was new information? 3
3 boys.
healthy boys. Okay? The chance of this individual to be a carrier is 1 out of 9, not 50%. Alright? And when, if we want to calculate the risk for this individual, then the risk of being 3 to be a carrier is 1 out of 9 multiplied by 1 out of 2. We calculate the risk for 2, but we need to risk for 3. Right? The risk of being a carrier for 2 is 1 out of 9, then multiplied by 1 out of 2,
2.
right, is 1 out of 18.
Mhm.
Right? Maybe she has some problem, right? Did you got it? You got it? You got it? Okay? So, at the beginning, we calculate the risk as 25% of individual 3 to be affected, to be a carrier. 50% for 2, 50% for transmitting to 3, okay? 50% multiplied by 50% is 25%. What's the exact risk? Because of having 3 healthy boy in this individual, the exact risk is 1 out of 18, not 25. Okay, you can have a break and then we will continue about the autosomal recessive risk calculation.